What do you want?
You taking a chair?
That's
Careful on that.
well, I think I'm gonna have to switch out to the other side of you so she can't do that during the meeting.
I was being helpful. It reminds me, my boyfriend had a transmitted on, the transmitted on this little electrode.
Yeah.
They can come over and turn it down, but I didn't know that I had it upside down in my hand. And so I turned it
up.
all the way. I was turning it down. Yeah.
You realize it's little shocks, right?
How do you do?
It was awful. But I'll never live it down. I felt bad.
Oh, okay.
Endurance battle.
Yeah.
Now you can joke with them as a friend.
That's
Yeah,
right.
I know. Yeah, he has like a spare bank, like 10,000 points now. Just for that.
Self, and the refills too,
Yeah.
that's the
He's
problem.
like, remember that time?
Yeah, exactly.
That's so great.
Yeah, you're right about that. I never got
Yes. Pearl stuff going on down here. It's okay, but not great. It's a core. In the room. Same stuff. Typewriters online? Yeah. Kirsten, really? Are we good?
Yeah, we're just thinking with so many people virtually, well, we need to switch things up a little bit for the breakout groups, but that's okay. How are you? On the left, yeah.
He's not in my contact.
It's so complicated.
Yeah.
All right, everybody. Let's see, let's call this meeting to order at 9:02. This is the OEB 2024 board retreat for the 2024-2025 fiscal year. We're here in Salem, and Rose, I guess we'll do a roll call for the record on the recording. Can you do a roll call, Rose? I didn't bring my sheet with me, sorry. Or maybe I can't be heard online.
Give me a second. Hold on.
Oh, yeah. Sorry, I forgot to bring a sheet.
All right. People online do introductions too, just so we know who's there.
That's coming up. Okay.
Wasn't prepared for that, Bill.
Yeah, neither was I. Right. I can do it. Ali says he's got one.
Oh, okay, good.
Tony Mann. Here isn't present.
Misty Wharton.
I am here.
Dr. Andrea Silva Laura.
Here.
Thanks, Andrea. Bill's here. Susan Miller.
Here.
Enrique Herrera. Michelle Dewberry. Bonnie Luisi.
Here.
And Robert Young.
Yes, here.
Sally Gerfeld.
Here.
And Cheryl Berger.
Here.
Like 10 out of 11?
Yeah.
Okay, perfect. So officially a quorum. So let's go ahead and get started. I guess the first thing on the agenda is Ali, welcome message. Is what I'm seeing here.
Just wanted to thank everybody for traveling down. I know it's a big day and a lot going on in your lives right now. Taking the time out of your busy schedules to be with us today is super important. We'll talk a lot about OEB in just a few minutes. I think we wanted to do some introductions first before we get to some of our first slides, but I think we have a lot of new board members today, and it's great to be able to see them in person and be able to spend a little bit of time getting to know them and especially during a stressful time. I think it'll be good for our hearts to have this time together and be able to talk about some of the next several months of what to expect in OEB's future and how we can address that as a group. So
We have a board round before introduction coming up.
yeah.
Yep.
So I'll start here. I'm Wally Hassoun. You see him, his pronouns. I'm the director of PEB and the Public Employees Benefit Board and OEB. This is my last week as the interim director of the Health Policy and Analytics Division in the Oregon Health Authority. I've been wearing two hats. Damien here has been filling in a lot of my duties with PEB and OEB over it's been 2 years. It was supposed to be a 3 to 6 month filling in. You know how everybody knows how this goes. Yeah, interim. But it's been a great learning experience. I think it's given PEB and OEB a lot of visibility within OHA and certainly given me a great opportunity to see, you know, how we can work within OHA and, you know, a lot of the bureaucratic agency that OHA is. And it's just been, I'm really looking forward to coming back to PEB and OEB and focusing exclusively on the boards, because that's where my passion is. I'm very customer service oriented. The best part of my day is being able to help people that are in distress, that are having trouble accessing their benefits, accessing a provider, or just having claims issues. And I think a lot of us that work with PEB and OEB experience that same feeling. So I'm good to be with you here today. Pass it off to Damien.
I also want to just extend a welcome to everyone, especially the new board members. It's going to feel like you're drinking from a fire hose for a while, but you're coming in at a real good time because it's not in the middle of renewal, as Cheryl and Sally experienced last year. So please ask any questions. Corner one of us during a break if you want, just so that you don't feel lost. We're going to try not to use terminology, although every industry has its own jargon. Benefits can have its own. So, you know, raise your hand, ask somebody, write it down. We'll make sure we get you an answer. So welcome. Bill.
Yeah, so Bill Robb, and I am your chair for the coming year. And this is my 8th year in OEB. It was an interesting ride. I can still remember fondly my first couple months here. And I don't know if those of you who remember the old board place we used to meet at, but I sat in the back corner under the convenient excuse I needed an outlet, and just sat there for months, just kind of learning. And then on the board, just really absorbing everything and really trying to understand all the cool things that were going on here. And there is a lot of good work to be done here as we guide our consultants in how to negotiate with our vendors and keep our value proposition as maximized as possible, right, under the rules that the legislator gives us. So it's challenging, it's interesting. There's a lot of great learning to be done for the new members. Not all of it you like, and some of it is very passionate. So really looking forward to today, going through all the bases again. One thing I want to point out is I did discover in my chair last year's board retreat, which had our goals, and I went through it over the weekend, and we did a pretty good job from this one over the year, and going through what we said we were going to discuss, especially clinical studies. One of the things that last year's thing had was an acronym sheet on the back, right? So I'll share this with people if you need to follow this, but this was quite helpful. And yeah, so with that, let's see, how do we want to do introduction? Let's do introductions, which is coming up next. Why don't we do the rest of your staff, then Mercer's staff, and then the board will introduce themselves with a little icebreaker. Okay, so let's finish with the OHA staff, if you don't mind. back table.
I'm Stephanie Dodson. I started 2 years ago as an administrative assistant. I am now in OEBB 1, and I work on the dependent eligibility team.
Hi, everyone. I'm Cindy Bowman. I'm the Director of Operations. So if you need anything, you can always email me directly and I'll help you out.
My name is Glenn Bailey. I'm the Policy and Program Development Coordinator for OEBB and for PEP too. And I work on new programs that come in, new benefit programs, new type of clinical programs, as well as I staff what's called the Strategies and Evidence and Outcomes Work Group, which looks at issues related to our programs, evaluating our programs, bringing on new programs, and healthcare quality in general. I'm also actually starting in January, I will be working with the as a legislative coordinator here at PEB and OEBB during this session.
Hello, my name is Ruby Castaneda. I'm part of OEBB and PEB's contracts and procurement team.
Hi, everyone. I'm Barry Burke. I'm the OEBB and PEB's systems and data manager.
And we have Margaret. And yeah. You want to go ahead and start, Margaret?
Hi. Yeah, sure. Hi, good morning. Can you hear me okay? Great. Hi, I'm Margaret Smithies. I apologize. I can't be there in person. I'm fighting a bit of a cold today. But I am PEB and OEBB's program development specialist, and I work closely with Glenn and other members of the team on implementing and evaluating PEB program and benefits with the vision of furthering the board's priorities. Also work closely with our contracted carriers and vendors to ensure that programs are delivering the service and outcomes we want for our members.
You want to go next, Sarah? Forrest or Forrest? Sharna.
Good morning. My name is Sharna Freehan, and I have been here for almost 3 years, I think now. I was hired as the focus person for health equity, which means eliminating health inequities for folks that belong to historically marginalized populations. And we work very closely with Mercer and different programs to increase health equity. I also do health equity reviews for the legislative session and coordinate with PMAC, WWCC, CL, and occasionally the Innovation Work Group. Thank you.
Sure. Then we have Rose Mann.
Hi, I'm Rose Mann. I'm the Board Policy and Planning Coordinator, and most of you will only talk to me through email or occasional phone calls. I get the board meetings and see out stuff together and send out to you and take care of your travel.
Can't see if we have anyone else on there. We have Sarah and Forrest, last chance.
Hey, sorry about the audio. Forrest here. I'm a communications coordinator along with Cindy and Sarah. Newest member of the communications team and happy to be here.
Thanks, Forrest.
And Lynn.
Oh.
Yeah.
I'm sorry, I didn't see that. Yeah.
Introduce yourself.
Oh, Lynette Howard, admin.
Thanks.
I'll take over from Mercer's side.
Yeah, actually, let's start with Maya in the corner, and then we can just go around the room.
Hi, everyone. Good morning. My name is Maya Welton with Mercer. I support both IWG and CL for both PEB and OEBB.
I'm Emily Abarisk, and I am the project manager for OEBB's Mercer side, or Mercer's OEBB team.
I'm Kirsten Staben, along with John Kessler, one of your lead consultants.
Yep, I'm John Kessler. I'm the other co-lead consultant.
Hi, and I'm Christy Ewing, and I have been supporting OEB with CIAO, also behavioral health. My education and background is as a professional counselor and then also a board certified health and wellness coach. And so with OEB, and PEB, I work very closely with Sharna and the OHA staff in the health equity work group, and then also help with behavioral health strategy and anything else that I can support.
I'm Sarah Drake. I support PEB and OEB from a pharmacy perspective. I'm a pharmacist by training. And so I support CIAO, other discussions around drug benefits and prescriptions.
Good morning, I'm Dr. Yin Shuang. I'm a family physician by clinical background. I am your clinical resource for OEB CIAO. Anything medically related, I'm here as your consultant.
Okay, we'll switch over now to self-introductions by board members. I'll start. Let's go with who you are, which seat, what is the title, what professional organization you're holding in your seat, how long you've been on the board, what county you reside in, and then a comment about what you feel is the most important healthcare concern in your region or the group that you represent. And I'll begin again. Bill Gropp. I hold one of the two OSBA, Oregon School Boards Association seats, 8th year on the board. I live in Marion County, and I think that out-of-pocket expense, healthcare costs to individual members is what my constituent, the people I look at, have the highest problem with in my area. We do have access, but it's just the cost, the overall out-of-pocket that's really concerning to most of my people that I talk to. Let's go to the online. Dr. Andrea Lara. Andrea, are you there?
Yeah, hi. Good morning. I'm sorry I can't make it today. I'm Dr. Lara. I'm a public health physician. I work with Oregon Health Authority. I use she, her, Ezra. My county is Multnomah County, and this is my second month on the board, so I'm pretty new. I think one thing I can highlight probably is quality of care. Something I'm really passionate about that is not only provide the support, it's also the quality that we support. So, and that's it. Happy to be here. Thank you.
Okay. Did Enrique join us online or not? Let's go with none. So we'll just go around the board members in this direction.
Bonnie Luisi, I'm from Umatilla County, Hermiston, and I represent the school boards that's my title.
Oh,
and I've been on the board here, this is beginning of my 5th year. And I think one of the things is access to healthcare and the costs and out of pocket, I think is a real big thing. A lot of our specialists are out of state, and so not necessarily in network sometimes, and so there's a big struggle to get coverage from a doctor that's been recommended.
I'm Michelle Dewberry, she, her. I live in Multnomah County, and I represent the Portland Community College Federation of Faculty and Academic Professionals. We have 2,000 members, and I think our biggest, I would agree with Bill about out-of-pocket expenses. It's even when you have insurance, it's you can't do anything without spending $1,000. So that's really stressful for our members. And then we also have a large percentage of our membership are part-time faculty, so they are. We do offer, PCC does offer health insurance to part-time faculty, but only if you meet a certain threshold. And so a lot of our part-time faculty, whether or not they have access to health insurance depends on whether or not they get assigned a class, and enrollment shifts and all the other kind of things, moving parts in our economy really impact our members. And so we really work in our union to try and shore up the job security for part-time faculty and increase the percentage of full-time employees at our college. So thanks.
I'm Robert Young. I've been on the board for 6 years, something like that. I'm one of the 2 representatives of the Oregon Education Association, and I think the challenge is the same as it's been for me for the past 6 years, is finding the right balance between affordability, cost, and access.
I'm Tony Mann. I am superintendent in the Multnomah River School District, representing the Confederation of Oregon School Administrators on this board. I'm also founder of Oregon Recovery High School Initiative, focused on high schools for adolescents in recovery from addiction. And I think that brings, in terms of a healthcare challenge, serve on governor's advisory around mental health, general well-being of children in the state. And as a member of the OEB board, I'm really coming as a learner here at the outset. So thanks a bunch.
Good morning, everyone. My name is Misty Warden. I'm the superintendent of Nestucca Valley School District, which is located on the coast in Tillamook County. I've been there for 8 years as superintendent, but it's actually the school district that I grew up in and went to high school in, so very familiar with the community. I also serve currently as the president of the Oregon School Activities Association, which is a crosswalk to this work about wellness and kids' involvement and healthy habits. So I really enjoy that work. And I would say in my area, it's access. Like the closest pharmacy is 20 miles away. And creating a network of resources that people in my community know where to go to get served. Because one of the greatest benefits we offer as a school district to our employees is this healthcare package. And so to create better access is important for us. Oh, and I've been on the board fewer than 90 days. I'm not sure how, but I'm new.
Oh, it's me, sorry. I'm Sally Durfeld. I'm the Classified Benefits Coordinator for Eugene School District 4J, and also on our OSCA Executive Board, Vice President. I would say one of my biggest concerns is affordability and I guess fluency for people, understanding how to use their benefits in the best way for them, right? Which is my job to like give that information, but for the people that I can't reach or don't reach out to me, that's kind of a big part of my heart is that education aspect.
Susan Miller, she, her pronouns. I worked in labor almost 24 years. In the political season, I always sound like this, so bear with me. I'm judging this based on Robert's answer. It's either my 5th or my 6th year. I can't remember now. As one of the big unions in the state, which is OSCA, we represent over 24,000 members in the state and are classified workers in the schools mostly. I live in Multnomah County for the most part when I'm not in my office, living there in Marion County, and I would say out-of-pocket costs and accessibility are #1 issues for our members.
That covers us. Sure. Oh, sorry.
That's all right.
This one, sorry.
Yep, that's all right. Thank you. So my name is Cheryl Berger, Human Resources Director for Hood River County. This will be the first orientation I've been to, so I'll get to see this full circle. I'm excited to see that. Jumping in the middle was a bit of a head rush. But that said, that's probably how my life functions in the world of human resources anyway. And so I'm excited to be here today. I come from Hood River, and I think one of the things that we have concerns with are out-of-pocket costs, but also we hear a lot of our staff and other folks talk about access.
Thank you. All right, who else is my limited brain size? Okay. All right, we're good. With that, let's get started with the start of the meeting. OEB mission. Marley, are you?
Yeah, I can take that. Okay. So last month we talked a bit about the OEB mission, I think, when the OEB board was created, they spent a good part of their first, I can remember I was there, I think a few other people in the room were too, a good part of the first 3 to 6 months really trying to define Senate Bill 426 and really determine how the board can really hold these tenets up and implement them in a mission statement, vision statement. And I think you can see the tenets below that were labeled as guiding principles that are really hold to this day. I think that we talked a little bit last week about employee choice among high quality plans. One of the interesting parts of Senate Bill 426 is the board had to offer the least value plan as up to the highest maximum value plan. So like say a Cadillac plan to a high deductible plan, and then come up with plans in between that would create high quality plans. Essentially, we're trying to address the problem of there just weren't enough high quality plan options out in the marketplace at the time that school districts all had access to, especially smaller to mid-sized school districts were really at the mercy of their own demographics, their own plan experience. From year to year, they could experience really fluctuating rate increases. So I remember the first year, gosh, I don't have a number, but it seems like there was at least 20 different medical plan options to get to. You have to provide a plan that's comparable to one that's being offered currently within the school district. And just a little bit of history, that first year of OEB's implementation, I think we were expecting a third of the population that was required to join OEB, and we ended up getting 2/3 because the other third were facing high increases, and OEB was a option that made a lot of sense to them fiscally and for their employees. So it was really an interesting rollout, but encouragement of a competitive marketplace. I think, that's something that we saw just this last year where we had a vendor that we were getting negative feedback on from our members, from employees, from our data, and the board went out for an EAP, RFP, and took action. We had a lot of interest, regionally, nationally, and OEB's business is something that everybody is interested in, every organization is interested in competing for. So I think that that's been a real win-win as far as when we've gone out to RFP, whether it be medical, dental, vision, or just recently for an EAP. Plan performance and information, that's something we have a plethora of data that we can leverage. We talked a little bit last month about PEB's opportunity for comparative data with another public large group plan to take strategic action to get information from our data, specifically around plan performance, and even build into contracting how we can best manage our contractors using data, using best practices, and we rely on Mercer quite a bit for that. Next is district flexibility in plan design and contracting. I think, the board has always prioritized offering plan designs that meet the needs of the district, not just the employer, but the employee groups, the employees within those groups, and the families with those employees. And Throughout the years, I think we've, again, started off at 20 plus medical plans, a multitude of dental and vision plans. We've kind of narrowed that down to a pretty good place, but I think even now, we do get feedback. There's too much choice, but then we get the opposite, argument that there's not enough choice. So finding that happy median is really a board task. It's probably an annual thing that we look at in the renewal process. Next is quality customer services. I'm a customer service person. That is what I'm most proud of. I think our customer service team, member services, we literally had no turnover on that team since day one. They are experts in what they do. We have 90+ percentile feedback in our annual customer service survey. I think they all wear OEB on their sleeves when they come to work, and they care about helping people, and it's complicated. And they do such a good job of explaining the OEB value proposition, which we'll talk about, and really making us all look good. And just really can't say enough about them. And creativity and innovation. I will actually talk a little bit in a few minutes about some of the national recognition that the PEB and OEB boards have recently received on innovative approaches to cost containment. I think that's something that's been at the forefront of OEB from day one. Is you heard about the COW group and talked to our new board members. That's Strategies, Evidence, and Outcomes Work Group. That's unique to OEB. They do a lot of exploration into innovative approaches to solving problems, as well as looking out to the future and how can OEB stay competitive within a competitive marketplace. And then plan benefits is part of total employee compensation. We'll talk in a minute about the value proposition that OEB provides, and I think how the board's always seen benefits as part of that employee compensation package. Certainly employees feel that way. How can we best deliver, and we're facing, massive inflation cost increases that are obviously experienced at the ground level. How can we continue to be as competitive as possible? And then the improvement of employee health. I think one of the things, Bill, that the board expressed the last 2 years is really an increase in communications, increase in resources. And I believe it was at the last meeting, we talked a lot about the tools that we provided that are coming on for employees to get the best information at the best time. We have our wellness coordinator, Teresa Pross, who I see has joined, who's done a tremendous amount of work moving employee health, something that we don't have a whole lot of resources for in OEB, but getting those resources organized at the school districts, at the local government, community college level, into something that we can really invest in. Something that the board can really look to invest in. Next slide, please. So leading into the vision, I think this really aligns with the mission and bringing a collaborative and innovative approach. I talked a little bit last month about you really do, and for our new board members, you really will see collaborative work environment with not just the staff, Mercer, the board, but also our carriers. We see them as partners. We often get issues brought to us through the board, from your constituents. And that's something that we can not just take among staff and Mercer, that's something that we work with our carriers, and they often come up with very creative solutions to problems, and we can work to implement that. And I think that's been a real, again, tenet of OEB is it's just working collaboratively as a state to really solve problems and be able to deliver across the entire spectrum of OEB. Next slide, please. So we'll talk a lot today about the 3.4% cap, call it test, that we're held to every year. I think what you see on this slide is OEB's sphere of influence, and that's these are all bubbles that OEB, the board has control or authority over. I think the influence of OEB and PEB across the commercial insurance market should not be understated. I think that, again, this is business that every carrier, every vendor would love to have, and we attempt to maximize our purchasing power as best we can. I think you'll hear about, again, those collaborative endeavors with PEB and even within the Oregon Health Authority, how best we can leverage that purchasing power is really something that delivers for everybody. That the value proposition of OEB is also a story we want every participating member and every eligible entity to understand. I think, witnessing the last legislative session, long session, that there was not one bill to be able to opt out of OEB or to eliminate OEB entirely is a testament to the board's work over the years to delivering on its promises, like you saw in the mission. And while that work still is ongoing, I think that hopefully this next long session that starts in a couple months, we see the same thing. But just the fact that there's so many local governments and districts coming into OEB voluntarily now is a testament to that work. Next slide, please. So conversely, these bubbles are not within OEB's sphere of influence. So in other words, what the board has little to no control or authority over. So many of these items are controlled by the participating entities, such as plan offerings that they choose to offer within that menu of benefits that OEB offers to choose from. Employer contributions are a big part of OEB communications that I think sometimes employees have the from a premium standpoint that OEB has some control over that, and as you all know, that's part of the collective bargaining process. So not a lot of authority the board has over that. I think just the ability for entities to maintain that flexibility and decision authority in their employee benefit offerings really allow for greater control in determining what works for each group and within each participating entity. So it's important that they have some influence over their own districts, their own local governments, their own community college offerings, that they have flexibility within OEB to be able to manage to that. Next slide, please. So as we get into OEB's unique value, I talked a little bit about this last meeting. I think all of these factors that we've been talking about really contribute to OEB's unique value. We really want to reinforce the purpose for creating OEB in the first place and going back and revisiting, through the mission, through the vision, what the initial boards, what the initial constituencies that created OEB were trying to achieve. And I think there's greater purchasing power across OEB more than ever. There's annual budgets now that can be set with confidence at a 3.4% cap. I think there's transparency, streamlined customer service, as we talked about. OEB has a seat at the table in conversations with the governor's office, which in my 2 years in this interim position, OEB and PEB are really seen as is a real player as far as state purchasing power and does have authority to influence policy. Again, OEB's attracted 2,300 new employees to the group in the last year and 9 new educational entities. So I think there's a lot more interest in joining. I think that's really a testament again to the work the board's put in. Excuse me. I did want to conclude with a note on OEB innovation and recognition across the country. So next week, I was invited to speak at a conference in Boston about Oregon, specifically having OEB innovations related to cost containment. We're one of 3 states invited to present, and they're sponsoring the travel. Our 3 presentations are sandwiched between Chuck Todd, who you'll probably see on TV a lot today, from Meet the Press. He's the keynote speaker, NBC's political correspondent. And then we give our presentations, and then the governor of Massachusetts is doing an address to the conference. So we were, again, identified as having something that would be of interest to really a state on the East Coast that's really more urban than anything like what Oregon, we've been able to accomplish, with a mix of urban and rural. And this is really all about you and the work that you've done. It's being recognized. We have a meeting with Colorado tomorrow to talk about this. We have a meeting with Washington as well. So it's really getting noticed across the country. And I say a lot of this with pride, but at the same time, I know as OEB board members, you have members coming to you with their real issues, their problems with access costs, what we talked about and heard from you. And this is what really truly drives the program, is how we can best respond to that as staff, as the board, as Mercer, and as our carriers. And wrapping this back around, I think that's what really drives us, and we're just really super excited to work with the board. Sorry about my voice, I'm getting over a cold myself, so it's about giving out. But I'm really just excited for the day, and thank you again for coming. Yeah, sure.
Was the 3.4% cap, was that part of SB 426, like part of been around since the beginning of OEB?
No, it was part of the Senate Bill 1067 bill in 2017. One of the things that other states are really wanting to hear is our hospital cap and the 200% of Medicare payment. That we think was really an offset to that 3.4% annual increase. So that was a way to have sustainable costs within PEB and OEB to be able to meet that that cost cap. So they both went into effect in 2020.
Okay.
Yeah.
Thank you.
Yeah. Other questions?
I'd like to chime in just one comment from me that at the last board meeting, you may remember when we were talking about the CL upcoming things, I mentioned that there's really 3 key stakeholders in the work we do in this room, which is our employee members, right? The district, the entities that deliver the plans that we provide to those people and at their cost and the employees' cost, and then the providers. Those are the 3 key stakeholders. But when we look around this room, we're looking at our OEB staff and the consultants that we use, Mercer, and then the board is oversight and giving guidance. This is how we maximize the best healthcare for our members and those stakeholders to give us the best possible outcomes for health and wellness, right? So this is the room that makes it all work for our stakeholders, and that's the work that we do. So.
Can I just, one more thing I wanted to share is for the first time ever, I've worked at PCC for, I don't know, 15 plus years, and I'm hearing rumblings from AFT and from PCC members about the 3.4% cap and wondering if we can do something about that, because the feeling is that costs are going up and like employees are bearing the burden of that. And so I just want, like, it would be helpful if for me to come out of this meeting with just a better sense of like how to talk about it with members.
Sure.
And I don't know how the board feels about the 3.4%
Yeah,
cap.
the board expressed that opinion.
Yeah.
The PEP board as well. And we took a legislative concept to the governor's office this budget cycle, but it wasn't approved to move forward. So
What was the?
We provided 3 different options. One is to have the test be over extended period of time, not just annually, because there's certain things that impact it annually, where you can have just a year that is kind of an outlier, and then the other one of them was to eliminate the cap and put in place we provided some different thoughts around how we could better approach it than just a hard cap. That it would be more in line with the statewide cost growth target committee. It's a target though, it's not a legislative hard cap of 3.4% that OHA is trying to implement currently. But there's considerations or exceptions that can be excused for exceeding that cap, which we don't have. Again, we have a legislative hard cap, so very different from a target. What was the other option?
So the other one was really what we came up with, was the way that it could kind of vary between a range. And that way also, in cases where we are below 3.4%, then instead of, what happens usually when we're below 3.4%, the board keeps it at 3.4%, so that we don't, see if we go down to 2, then we have to make it back up to 5 next time. So what you did is the board would keep it at 3.4%. Bottom line was, by allowing this range, then we could pass on more savings to the entities.
So I think my feedback in discussing with the governor's office was that it wasn't a good time to be considering this. There's provider tax negotiations, which involve really the entire healthcare marketplace, that they need to really get everybody on board and buying into these new taxes in the system that extend over several years. So allowing OEB, and there's also the cost growth target committee I mentioned. They're trying to kind of hold payers' feet to the fire in this next year, and if they allow an exception here with PEP and OEB, it would be a difficult proposition for them to go and enforce accountability across that group.
Is the legislative concept to the governor's office, is that's one route of getting some legislation introduced, but is it
It's
possible?
the only route.
It's the only route, like,
yes.
so it couldn't come through, like our members working with one of their legislators?
Yeah,
or-
oh, absolutely.
But that goes to the LC.
Okay,
Your
Yeah.
legislator still has to introduce the bill through the LC.
okay.
Yeah, it doesn't have to be staff, our route is only through the agency and through the governor's office, but anybody can introduce, a constituent of OEB can work with the legislator to introduce a bill that would amend, if not repeal. But there's always danger in opening up statutes.
Yeah, I
Yeah.
more curious than anything.
We talked about the hospital cap, the 200, that's a real value of OEB and PEB and that others don't have. And that's something that there's players within the market that would love to get that repealed. So, yeah, we're hoping that doesn't come up this session. They tried.
I think one good thing that came out of the whole process was we were able to really educate a lot of folks at the governor's office about the issues around the 3.4%. So there's a much better understanding of it now. So as long as the players don't change, we have that groundwork laid.
Yeah.
Yeah, the OSBA see that's, you know, there's the additional complication that you would also have that as we adjust our member plan costs, but that also then feeds into the school budget cost because now you're trading things through and it gets very entangled, especially with current service level being recalculated and all these things. There's just a lot of tangled mess of how this rolls around that a lot of legislators don't adjust. So, but even as like for me or something as an ex-elected, now I have to get a sponsoring legislator if I have a great idea. I still have to find a sponsoring legislator to take that idea and put it into the process for me. That's what the agency does, and it could be the governor too, right? But that's how the introduction goes into the system. But I think Robert mentioned in his introduction, you know, it's a really hard time when you have this cap to balance that cost limit with the quality of healthcare, you know, in a system that is now almost double, more than double what we're capped to and how to maintain that. But we have maintained, we didn't really eliminate a whole lot of things, but we've gone to efficiency through the help of Mercer, you know, and just getting that efficiency calculation higher so that we can maintain what we do current service level and yet stay at that 3.4% cap when it's 8% nationally. There's lots of good ideas on the table that are coming from the team, of course. One of the things I don't know if we, but having some exceptions to the 3.4% cap on a national thing, but as an ex-elected, one of the things we talk about is don't hold it here and then have a massive step, right? Take it on a slow ride up is way better than trying to hold it and trying to explain to somebody, well, we haven't raised your rates for 5 years, and guess what? They're up 15% now, right? Good luck, right? It's not really the best way to do things. So that's also the kind of the concept of keeping that 3.4% regardless of how it goes, because you're putting money aside for those bad years that are coming, balancing through. Not sure I'm helping, but that's my point.
Thank you.
Right. Okay. I'm not sure who's doing the review background. Is that Mercer?
Yeah, John is going to do that.
I'm going to do that. So if you move to the next slide, and you notice it's not exactly the slide that you have here because I pulled up two slides from the appendix that I thought would be good to provide some context. So before we embark on our strategy discussion and the fun strategy breakouts and stuff this morning, we thought some data would be probably a good background to cover. So, and also I just want to point out that this is data from last open enrollment, because the thing is the data from this open enrollment is just becoming available now because, you know, open enrollment is less than a month over. And so we should see that probably either in our December meeting or in our January meeting. So the thing is, just for context, but I think it's still useful to help. And again, I won't focus as much as the growth and then just really just the basic numbers. So I think, and there's some additional slides in the appendix, you know, for those who want some additional detail. So let's see. So I think the key thing out of this slide is really looking at, you know, the enrollment. So that if you look at the enrollment for medical, dental, and you know, is pretty much the same, and then vision is slightly lower. Vision saw the highest growth in the last open enrollment, followed by dental, and then followed by medical. And then if you look at the different carriers, the growth for, you know, for medical was roughly equal for medical. You know, it is equal for MODA, and if you're looking at the percentage, not subscribers, obviously. Pretty much the same growth for both Kaiser and MODA. Slightly, you know, pretty much the same also for Kaiser and Delta Dental when you come down to dental. And then you get to the interesting piece is seeing the growth in VSP of 8% in the vision. And then, you know, our thinking is that people are better understanding the value that VSP is bringing in terms of, you know, what their premium is and what the benefit is. So I think that one of the key drivers of growth. And I think overall that, and you'll see this theme as we go through the data, that there's a fair amount of stability here. So, so barring any entity budget-driven changes, we would expect small annual growth. And some of that annual growth goes back to just the discussion we had about the 3.4%. This is really what's bringing people in over time. Because if you think that people are having, increases, a lot of entities that are not part of OEB are having increases that are greater than 3.4%. Over time, OEB is just becoming more and more attractive to them. And you're seeing that with some of the entrants of the larger school districts coming in this year. So, and also ask any questions as I go through this. This is going to be better as a conversation than a monologue. So with that, I'm just going to keep moving on to the next one if there are no questions. So this is really just the breakdown. So this is really interesting, at least from a geeky consultant perspective, because you can see that most of the enrollment, like 54%, is in PPO type plans. And then that's followed by HMO plans with around 27%, and then 19 in the HSA plans, plans of the high deductible plans that are associated with HSAs. So this plan mix has been relatively stable, and we'd expect that to remain so unless you start changing plan designs. So what you're seeing too is what's interesting is that, so not only is PPO the largest category in terms of where people are enrolled, but it's also the fastest growing category. So, but 3.2%, followed by HMO, which is 2.2% increase in the last open enrollment, and then you can see people, pretty much a small drop in the HSA. Not a surprising, based on the discussion we've already had this morning around out-of-pocket costs. And so this is kind of relates back to that discussion.
So John, is HMO exclusively Kaiser for this? Okay.
And we'll get into that later. That's a really good question, Robert, too, because Kaiser is also not universally available. It's just available in certain areas, and we'll talk about that. Actually, I think on the next slide, well, we're getting there. So this is the geography, and I think this really is a helpful slide too, because you really kind of see that concentration of enrollment, in the Portland metro area and the I-5 corridor. So that's about 78% of your enrollment is in that area, including the I-5 southern piece of the I-5 corridor. And this really gets to the other thing that we're talking about today is access, because then after that it drops off pretty far down to central is 6.9, coast is 6%. Then you go to the northeast with 5.3, and then the southeast at 1.8. So I think the challenge is that the provider distribution follows the population distribution. So, and this really kind of speaks to some of the access issues that during the introductions, were mentioned during the introductions.
So John, would you say if we did the map on this for providers, it would pretty much line up exactly the same way?
Yeah, very similarly. Just because you have so many of the school districts are in OEB, and then it's reflecting and the school districts are reflective where the populations are. And so again, this is something that's been fairly stable over time as well, and we'd expect such. Okay. So this is really about choice. So I think that this is really interesting. So I think it's important to recognize that the entities decide which plans to offer. So this is not something that OEB decides. OEB provides a range of plans available to the entities, and the entities make that decision. And it's pretty clear from this that both the entities and the employees value choice in terms of the plans that they're offered. And we talked about, how Kaiser is not offered statewide. So Kaiser is offered in the Portland metro area, Salem, and Eugene. So it's pretty much just that, part of the I-5 corridor, but not all the way down. And as such, only 36% of entities offer Kaiser medical plans. Kaiser has 4 plans that they offer, and plus the bronze plan, but more on the bronze plan later. Don't want to get distracted with that here. So there are 3 HMOs and 1 HSA compatible plan. That's what the Kaiser's offerings are. 77% of the entities offer 3 or more Kaiser plans, and 39% offer all 4 Kaiser plans. And then moving on to MODA, MODA is statewide, clearly. They offer 7 plans, 5 PPO and 2 HSA compatible plans, plus the bronze plan, of course. 85% of entities offer 3 or more MODA plans, and then 38% of entities offer all 7 MODA plans. Now, a little bit on the bronze plan. So this is a plan that was implemented in October of 2015, and has a distinct reason for it. So essentially, this was a low, it was introduced as a low-cost plan for entity employees who are full-time but not benefit eligible. So this was what the role of this plan was. And the plan is limited to employees and their children. As you can see from the slide, no entities offer the bronze MODA plan, and 1 entity offers the bronze Kaiser plan. So really more of a footnote, something that was implemented and not necessarily availed of. So
can I ask a question? Why does it still exist then?
That's a completely fair question. I mean, I think it's, it's something that can be looked at. So I think the other, again, this is another interesting, these next 2 slides kind of go together. So the first one is really about, how in an open enrollment, there's not a lot of change across carriers. So the thing is that there's a lot of stability in the OEB plans, which is a good thing. So in a typical plan year, such as this last one, you kind of don't see a lot of changes, across all 3 coverages. You're seeing slightly higher, as you can see here, in vision. Not a surprise, since we saw that increase in VSP earlier. Let's see, what else? I mean, so switching carriers is pretty uncommon, particularly in the medical and the dental. You see a higher proportion of switching in vision. And again, that was something that we mentioned earlier around the VSP. You saw that 8% growth in the VSP enrollment, and that's really related to, and we know the new growth was less than 8%. So the thing is, that indicate that delta is the people that are switching. The other thing to note from this is really just the fairly limited piece that's really around disenrollment. That's typically related to turnover. There is turnover. Being an educator and an assistant is a tough profession. So you do see turnover, and that's actually a higher percentage of turnover than for switching, but both are relatively limited.
You don't find an impact from retirements?
Yeah, that's part of it as well. Yeah, that's right. That's a good call out. And you probably see that in your, yes, yeah. So I mean, I think that was interesting how the pandemic impacted the retirement patterns as well.
It did.
So, yeah. So good comments and questions. Appreciate that. Okay. Moving along, so not only do people stay in the same carrier, but they also tend to stay in the same plan. So you see for MODA, 86% of employees stayed in the same plan. For Kaiser, it was 94% stayed in the same plan. And again, you're seeing roughly, it's not surprising that you're seeing more plan changes in MODA because there are no more plans to change to. Again, there are 7 MODA plans, 4 Kaiser plans. So the other thing to kind of pull from the slide is also, while employees enrolled in Kaiser are kind of equally likely to have moved into a richer or leaner plan, the MODA switchers are going more into the richer plans, slightly more likely to go into the richer plans. And when we talk about richer and leaner, just to make sure that we're all on the same page, so a richer plan has lower cost sharing, lower out-of-pocket costs. A leaner plan has higher cost sharing, deductibles and stuff, and out-of-pocket costs. So I think the other thing to recognize here that a lot of this is also driven by the entity level decisions around contributions, right? Because a lot of plan decisions are driven by contributions, and that's not something that's within OEB's purview. Go ahead, Robert.
I was just going to add to that. When we bargain our collective bargaining agreements. We try to make sure the employer's contribution is at least 3.5%, so that, you know, they maintain the same level. So that drives the stay. And we have some that actually do a little bit better, which allows them to move up a plan. And I can't remember if the trend on going richer has always been higher than leaner, but I think when I started, it was the opposite direction. So I think this shows a little bit more health than when I started.
And I think that you kind of raised a very good point around that 3.4%, because it brings the greater budget predictability for the entities, and then also from a bargaining standpoint, it kind of gives you a target in terms of setting, you know, the contributions. So the thing is that people are not, you know, worse off going forward. Okay. So we'll move on to the next slide. And this is around race and ethnicity reporting. Again, just a little bit of background. This is information from the OEB enrollment system. You know, that's the current source for this information going forward. You know, over time, this information will likely be collected from the carriers. And again, there are some pieces of legislation that have been passed in recent years around this. In Oregon. So in 2021, there was HB 3159, which addresses SOGI data. And then let me not lapse into jargon. So SOGI is sexual orientation and gender identity data. And then there are also earlier legislation around race, ethnicity, language, or disability, which is the Real D part of Real D and SOGI data. So again, a couple things to point out here. So again, largely, this is self-reported. The other category includes people who decline to respond. So I think that is probably throwing things off a little bit. But I think the rest of the data, you know, it shows you the distribution. And again, there are efforts underway by the state to improve the collection of both the Real D data and the SOGI data. And that's something that's going to be likely done through the health plans going forward. So any questions? That's really the section of, you know, some of the background data we thought that would be helpful before we dive into the meat of the meeting today.
John, can I ask one more question?
Please, yeah.
So the data, the SOGI data and the things that you talked about, you then we examine that as a board, and that helps identify the types of benefits within the healthcare plans that we might want to pursue.
Yeah, again, with the demographics data, as you'll see today. And then also we look at the condition data. So this afternoon, you know, Ian will walk us through some of that as well. So it's really, I think it's part of the broader context of how does, yeah, exactly. How does OEB better serve its members?
Yeah, it's what allows us to identify gaps in care, because when we have overall OEB data, it can look like, wow, our cancer screening rates are excellent. We're at the 95th percentile. And then we drill down a level and we look by OEB region, or you'll see later this afternoon, behavioral health diagnosis rates by gender. We'll look at race and ethnicity and we'll see, okay, maybe the average isn't telling the whole story, because we're going to miss some people if we don't go the next level down.
Yeah, I think that's really a good point, because the average kind of hides a bunch of.
In most everything.
Yeah, exactly. I think it's, yeah. So I think that's it. So I think we're ready to move on to our next section, unless there are any more questions.
One additional question, and I appreciate that discussion on disaggregation for sure. On the very first slide, with the regions at the bottom, I want to just eliminate any assumption I'm operating on. This is out of state, 1,313
employees.
Yeah, and those are employees that live outside of Oregon, but are employees by.
Yeah, exactly. You know, likely, you know, Idaho, Washington, California. Yeah. Good question. Thank you.
I just want to start, let's do a quick time check. So we want to make sure that we get you into breakout groups on time, so that we're not robbing you guys of your discussion time. It's the most valuable part of being here in person together. So we want to make sure that we get to that by 10:30. We'll have an hour set aside for group discussions, and then we'll come back and have, if you guys remember from from last time, some of you will have each small group nominate some goals. Hey, our group would like to recommend, A, B, and C. We can put those up and go through a voting process. So to make sure we're not rushed in goal setting, because that really is the key for today, want to start that right at 10:30. We have currently scheduled a break at 10:50, which would be maybe right in the middle of that. So I was wondering, we're free to keep that. Also, we could have break maybe at 10:20 and then come back and do goal setting uninterrupted. Might make sense too, in which case we'll set some context for goal setting in the next 10 minutes.
I think Andrea may have had a question.
Oh, Dr. Laura, do you have a question?
Yeah, sorry. It is regarding data. Do we collect language data? Because that's in Soji and Real D, so probably if we can have that data will be great.
Yeah, I agree it would be helpful. We'll have to look into how that's going, Dr. Laura, and let you know.
Sure, no problem.
Yeah, thanks. So this, let's be thoughtful about how we want to spend our next 10 minutes, because we really have too many slides to go through, which is fine. We can handle that for sure. So let's make sure we just touch on what's important. I think I want to start by reflecting back to you some things that we've heard already this morning. I don't know if you've realized it or not, but I feel like just the process of articulating what the challenge has been in your own area, you're almost in a way putting forth potential goals for the group to consider. So you've already been doing the goal setting process. Maybe you haven't quite realized it yet. And lots of things were coming to mind as you were talking. We heard, many of you mention out-of-pocket expenses for my members. That's not surprising, right? The economy has been really tough for people. Access, we know we have a statewide population within OEB, and access in particular in our non-urban areas is always a challenge for us, especially when we want to do something other than just virtual. We heard quality of care mentioned, we heard wellness, mental health, Michelle, and we heard member education in general, but also some specific examples. How do I message to my members the value of 3.4% so it feels like a protection and not a limitation? So all of these you're going to see as we do a little bit of background, you're going to see these things actually the board has worked on already. And when we go into the goal setting process, the goals don't have to be new, right? We can reaffirm goals that are currently in place. We can pull goals that were in place before December because they're popping up again. They're what are relevant to your members still. So on slide 18, these are the goals that were in place before the December 2022 retreat. And in that retreat, that's where we set our new goals that we've been working for the 23-24 and 24-25 plan years. And you'll see these were meet the diverse needs of our members. So I think about access in rural areas, find efficiencies. Bill, you mentioned the importance of efficiency as a way to free up money for benefit initiatives as opposed to just increasing cost share. Meet the 3.4% budget cap. Certainly that's always there. Mercer might propose that that's not a specific goal because we know that we have to do that anyway. And if we already know we're going to do it and we have a process for it, maybe we could focus on something new. Meaningful choice of plans, maybe similarly. Sustainable and affordable rates, though we heard out-of-pocket costs mentioned multiple times today. So in the afternoon, Dr. Twang is going to lead you guys through a strategy setting process. So the way we can think about it, this morning we'll set our goals. These are the big outcomes that the board wants to achieve over the next 2 years. And then in the afternoon, the strategy really focuses on what are the specific tactics that we want to use to achieve our goals. So as we look at some of the highlights for how the OEB board achieved the goals in the past, those are good examples for you to keep in mind of potential tactics for this afternoon. And again, we don't have to be reinventing the wheel. If some of these tactics seem appropriate to do again or to continue, we can. But I just want to highlight a couple of these. And you're welcome, obviously you'll take these home and can review at your leisure. But we've dealt with access. I think access is a continual conversation for us because we make progress on access and then we still want to do better because we're always driving towards excellence for OEB. So we've grown the behavioral health network, added offerings with that. We've also, that was pre-22, but also last year we added behavioral health access performance guarantees to reinforce the message around behavioral health access. We increased accessibility through expanded digital healthcare options. That was pre-22. Also for 24-25, we added Teladoc, which is the same thing. It's primary care, ideally for the purpose of expanding access in rural areas. We did a lot of work around quality through value-based payments, coordinated care, which is, so Kaiser has the HMO plan. They would say they're 100% coordinated care. That's the Kaiser model. MODA has coordinated care plans also. So they have providers who have agreed to function like a coordinated care model. And we have about 83% of OEB subscribers now in some form of coordinated care model between OEB and between Kaiser and MODA. And along with that, we've been working on alternative payment models, moving away from fee-for-service, which also improves quality. And then a couple things too around affordability. So we added a lower cost deductible plan, also added the 3.4% trend guarantee, which I know we've talked about as a board before. Maybe some elements of that, there's a little bit of a difference of opinion, but it has saved us from having to make benefit cuts in the past.
Can I ask another clarifying question?
Yeah.
I'm sorry. Okay.
Yeah, we like that.
So my entire career, I've resided in a non-Kaiser access district. What determines the boundaries of Kaiser? Because for me to drive to Salem to get care, if there's a Kaiser provider, I can do that even though I live at the coast, right? So what determines an area that's covered by Kaiser and an area that's not? How is that determined?
It's really based on zip codes, vary our system, how they.
Yeah, I can talk about that. So Kaiser gives us a list of zip codes where they have coverage area. I believe Mercer, correct me if I'm wrong, analyzes that to make sure that there's adequate.
We don't analyze it, but yeah, go ahead and we can add on.
Yeah, and so then the system limits the plan choices.
Based on where
that
people
zip
live.
code.
Yeah. Are Kaiser plans better than the other plans?
They're just different. People who are in a Kaiser model, they love the Kaiser model. They think, you know what, I don't want to spend time on a provider directory researching the best provider for me. I don't want to take that on. I want to delegate that to Kaiser. And all I want to do is just call and say, hey, connect me with the PCP. And then that PCP says, oh, here's your specialist and go to this location. Here's your alert reminder. So it's a very hands-off approach. But other people just have the personality where they want to be able to Google best doctor at OHSU for, you know, condition X, and then go see that person and have it be more self-directed. So I think it's really just a style preference.
Yeah, so I'm just looking through the lens of, you live in a zip code and you're limited to access to Kaiser, right? I would love somebody that took care of everything for me, and that's, I just don't, that doesn't make sense in my head about equity, right? So I'm probably poking a spot right now, but it's a question I've always had. And I realize the I-5 corridor is where a majority of the enrollment is, but rural people would be willing to drive to a Kaiser provider because it's, you drive an hour for anything anyway.
Yeah, I've always actually have that same thought. There are people that aren't in a Kaiser area that would be wanting to drive there.
Yeah, 100%.
Probably the precedent for this is that members don't accidentally enroll in a plan and then find out that that's further away.
Well,
just being ornery, just.
I worked in the Kaiser system for more than 20 years. And part of it is we had a lot of retirees that said, I want to live on the coast, but I'll drive.
Right.
And they would for the normal doctor appointment. What happens when there's a stroke or something of that nature where you can't get, it's not just about primary care, it's all the care you can get. And that's why, that's one of the reasons they don't allow it. There's also the HMO Act with licensing that they've got.
Access.
So that makes sense to me. So in essence, in an emergency, I'm at the coast, there's no Kaiser hospital to run to the ER. I'd have to come to Salem to have any type of health insurance coverage on that incident.
Yeah, well, if you live there, yes. If you live in Salem and you're on the coast, and you have a crisis, they'll take you to any hospital and they'll take care of it.
Gotta live life.
The same as when you travel abroad, they take care of that horrible cancer breast.
You live in the I-5 corridor, and your options just get larger. Okay, sorry, I'll shut up now.
I'm sure your viewpoint represents many members
It
statewide.
does, yeah, I've always been curious about that. Sorry.
Yeah, it's a good thought. I'm sure Kaiser's thinking, we'd love to expand into your area.
Yeah.
It'd be nice.
More choice is always great.
Yeah, more choice is great, and it's OEB's mission or vision, one of the two. All right, let's move on so we keep ourselves
I
on.
won't derail us anymore.
No, your questions are great. Thank you. They're really great. On slides 21 and 22, we show two things at once. The goals that the board chose back in the December of 2022 retreat. And I know we call them slightly different things each time we present because of the kind of the context. But one of these was shift left, which is this idea of early intervention. And it encompasses a lot of things. It encompasses wellness and prevention, and it encompasses using technology and taking advantage of innovation to help our members, catch their disease, ultimately prevent it or delay it. We also had the goal of member education, which that came up again today. We do so much for OEB members, and when we were reading there's a recent Oregon teacher survey, and it was just clear in the survey, people didn't realize the benefits that they had access to. And we know it's a challenge. We do so much for OEB, you guys do so much for OEB and have added so much to the offering over time. It's such a balance between how do you make sure your members know without inundating them with too much information. So member education was a goal. Also, quality and efficiency were goals too. Making sure we're offering high value care, the best care for the lowest price. And then of course, 3.4% cap, which I think really we should call that affordability also, because really we achieve 3.4% cap. The result is that the premium increases are more affordable than in the commercial market. So some ways that you, the board, have achieved that over the last 2 years. We've really done a lot around cardiometabolic disorder and shifting left on that treatment spectrum. So adding lots of different options for weight management, type 2 diabetes, and prevention. The communications team in partnership with OHA staff has done a lot to revamp the communication materials going to your members, updating things for readability, continuing to send the monthly benefit letter, adding a Spanish version of the OEB Wellbeing Guide, adding expanded translation services through MODA, and then all of these things expand access as well. Not always access to in-person care, which we know is different than virtual, but we've added Teledoc, Mighty, Omada, Verta, they're all virtual options for your members.
And for my seat, that's amazing to be able to have that as an option for us. That's super.
Yeah, that's great to hear.
Yeah.
Can we sync up the slides with what you're talking about for the folks?
Yeah, Emily, can you jump to slide 22, please? Yeah, thank you. And actually, we'll just go straight on to 24 because I want to keep us on track. Just based on the things that you guys said during your introductions, and Emily, if you go to 24 for us, thank you. One more. Oh, strange.
It's because we drew.
Oh, so I have to plus 2 every
Plus
time.
2, yeah, sorry about that.
I
That's
see,
my bad.
making me do math. Get my calculator out. As we go into the goal setting process, Ali talked earlier about the things that are within OEB's influence and the things that are outside of OEB's influence. And we acknowledge the importance of the factors outside of OEB's influence. Dr. Chuang is going to talk later about how most of the factors in influencing member health are actually outside of the member's direct control and outside of OEB's influence as well. But we do the best we can within our own sphere of influence. And that's important to the goal setting process because we want to make sure we set goals that are in areas where we actually have the ability to make changes and to make a difference with the strategy that we execute this afternoon. We also want to make sure our goals are impactful, and there's a balance here between things that impact most members or most dollars, or at least a meaningful number of members and dollars, but also keeping in mind that we're also trying to close gaps in care, which sometimes means focusing on a smaller number of members or a smaller number of dollars, but of course it's not less important. And then I want to make sure Christy has the opportunity to talk about the health equity slide, and we're just going to we'll go ahead and skip the rest and move right to our break and then breakout groups. The remaining slides, I can sum them up in like 3 sentences for you. Mental health seems to be an ongoing challenge for educators and assistants nationwide and within Oregon, and we wanted you, the board, we've heard from you before that that's the case, but we wanted to hear again for the members that you represent, is mental health, burnout, stress still a challenge that your members are facing? Yeah. Tony, what about you?
You're posing that question.
Yeah.
Yeah, I think anything I would say would be qualitative in nature. But the, again, I don't know that it'd be difficult to discern whether or not my assessment on a qualitative basis would contrast with other industries. But I'll tell you, it is, yeah, yes, exclamation point.
Yeah, double.
Yeah, and we have some quantitative data later actually too, just to make you feel a little more comfortable about commenting on that too. That supports it's still going on in OEB's population. And then the other things are just some healthcare innovations, and basically we can say that technology is a blessing and a curse, just like it is in education. I know there have been some changes this year with regard to like cell phone usage and cell phone signal in the classroom. So we know that it brings opportunity and challenge at the same time. So there's a lot going on in healthcare with that. And then the other slide just really hits on health equity, and Christy can reinforce that with this slide, which is we try to integrate health equity, closing gaps in care, the diverse needs of our members, meeting everybody where they're at, into all of what we do every time. So we're always thinking about, the majority of members, who's getting left out, what else can we do? Are we missing anybody? And so it just talks about that, that nationally as well. So we'll let Christy walk through the health equity slide, and then maybe Bill will take a break, and then we can come back and do the actual goal setting process.
Thanks, Kristen. Yeah, so again, really integrating health equity into everything we do, all of, the way that we look at programs, resources, any type of benefits changes that are happening. And I think, Kirsten, as you said, I always think of it as technology really lately is where, it is, there's such opportunity there, but then there's also lots of challenges. And speaking to Dr. Lara, your question earlier, I think with language capabilities, that's one area where it's like technology seems like it's such a way to open up access, but we are finding that lots of vendors and lots of technologies available are not yet in languages or designed in ways for everybody to have access to those. And so that's one area in particular that our health equity work group does look at. And it's a lot of really pushing. And, I know our communications team and Cindy would really speak to the fact that some of our vendors are not moving very much on that area. So it is really important. So we really try on the health equity work group, as you can see here, you all today, are going to right now this morning look at the broader goals for OEB. This afternoon is where we will look more at those clinical strategies and the tactics. And that's really our direction then. CL will take that as well, which is that strategies on evidence and outcomes work group. And then we work in tandem through CO on kind of taking that direction. And then we have what's called a health equity screening tool. And we really use that as our way to then go through and look at individual programs. We have lots of back and forth with vendors, the carriers, and then our group has discussion. And then we provide back to the board kind of considerations, like this is what we found, this is our concerns, or this is, a strength, an opportunity. And those are brought to you then in your decision-making process. Any questions on the health equity?
How about questions on
goal setting process, just the process that we're about to go through, breakout after a break. Everybody got thoughts on that, or you want to bring up questions? I have a funny story that I'll say before we break, that I was on the doula group 2 years ago that determined the purpose and the reasons for bringing in doula. I met the woman. She's a clinician, so she's in the medical community, but she just said in the middle of birthing, she lost English. She could no longer speak English. She doesn't know why. She can't speak to it today. But if she didn't have a doula that spoke Korean in the room, she would have totally lost contact with all of her medical providers that were helping her. She was amazed that she can't explain how that happened, but she totally just lost the ability to speak English in the middle of that crisis. And if that happened, then you take it down to like you're having a crisis at home, and suddenly you lose that ability and you're trying to get help. What do you do? Right? Something I would never have considered, but when I met that one, it was like, wow, that makes a lot of sense. So, stuff like that, when we talk about equity and things, goal setting, and just understanding different perspectives.
And if people haven't noticed, thanks to Cindy Bowman and her staff too, they brought coffee and hot cocoa, and there are some other things that you can grab on break.
There's also water in the fridge in the room right next door, if that's your preference.
Thanks, Cindy.
One more thing I'll say is because I don't know if this is a good thing or a bad thing, but shift left kind of came out of my mouth 2 years ago. And it's a concept that we use in a lot of different fields in marketing strategy. But the concept being that how to get the member to engage with the health community or the health environment earlier in the disease progression, right? Whether it's just a momentary thing of the flu that's going to go bad or something major, right? How to have a system that brings that person to the medical field earlier in the disease process, right? Because then it's a lower cost and it's an easier time to do it, and how to get the medical process to be more engaged earlier. That's what shift left means, right? So, just bringing that member's ability to come into the medical community sooner than what they're doing now, which is they show up at the ER because they're about to pass out, right?
Proactive versus reactive.
Essentially, but how to do that. On an education side, one comment I got from a member, which was totally unexpected, was this woman who's a high school teacher, just said, look, I attend the webinar and I learn everything about the upcoming open enrollment, and I've got some good things. Okay, I'm going to think about this. And of course, that's in August, right? So the next week, you go to the best ever 3-day PD session you've ever had, and your whole mind is like, I'm going to revamp, I'm going to do all these great things. And then open enrollment comes in September, and you're just like, huh? Right? You totally, that's gone, right? So, how to make that in some way that the teacher, and those of you who are COSA members or union members, that's how teachers, you go to a PD that you really enjoy, and suddenly the life starts over again, right? Your mind is now refocused on something. And I was like, wow, that's an interesting thought that so you had the education, but it's lost, right? It's lost due to another priority. So those are things that I've heard that I've learned over the years. Right? So just throwing those stories out there. And anybody else before we take a break? All right, let's go till 10:40. I know it's a little later than what you hoped for, but close enough. Right?
Yeah, I think we're right on schedule. No worries.
Yeah.
Thanks for coming out on this.
Pager.
I'm bang my head on the table. Alright, did we do assigned groups or how did we do this?
They're assigned.
They're assigned? Okay, because I know there was talk about updates. So I think we have enough people here that we can use the assigned groups that you originally had, or do you want to change it?
John Conference, Dr.
Yeah, I talked to Laura.
With him on his.
Okay, so you got that?
So we're all set to stick to the groups.
All right, so we had 3 groups, right?
Yeah, and they're up there as well.
Oh, great. So let's see. Group 3 here, because I'm old and I don't want to walk anywhere. Group 2 over in that corner, and group 1 over here next to the booth. Okay. Well, when we go into groups, I don't know if people, it's just going to sound like gibberish, right? So group 3 up here, group 2 in the back corner there. No worries.
Don't even know my food in my teeth.
Michelle, are you our spokesperson? I was going to let you.
Okay, group one's core goals were, one, to reduce member pain points, meaning there are a few points in which we identified that kind of caused some barriers or pain spots for some of our members. One being the coordinated care, the CCM. Finding a way to make that easier to use. Educating our employees on the CCM, how to make that work. And, we can talk a little bit more or elaborate a little bit more on that if you want. But there's still a lot of employees that don't know that they first have to assign somebody, right, as their PCP 360. And then there are kind of unintended consequences, if you will, if you do not, right? And so how do we make sure that members are doing that they know to do that before, and just making that CCM easier to use in itself. Simplifying plan design so that they're not so complex. Might be able to make that sound a little more eloquent than I am, or what that really means. But I think that, in potentially not necessarily having a CCM, right? And simplifying plan designs that way. Member communication. I think we decided to have that be member education, because, right, we're already, I know OEB does a really good job at communication, so does Lotus and Kaiser, but it's the education piece. Offering, entities can offer in-person education sessions, like how to use your MODA dashboard, how to use your Kaiser dashboard, how to use your benefits, how do you navigate your benefits, how do you assign somebody as your PCP 360, how do you even look for that, right, those kinds of things. So member education, how do we expand that, make that better for members? In my experience, I do a lot of Zoom education sessions. I, got a bajillion emails, right? But what really gets the employees the most is when I'm out there in the field, going out to schools and doing all of that, right? Or offering in-person education sessions. So can OEB help entities do that? How can entities do that to make that information more accessible? Not everybody learns in the same way, right? So accessing those emails, we're all busy. That's not always the way that you learn best anyways, even if there are videos or Zoom. Some people don't know how to access Zoom, right? Or that's just really not their thing. They're not tech savvy. So expanding ways in which to educate our employees. Growing OEB, so figuring out how to get more entities under OEB, right? And getting more entities under OEB, it makes us bigger, stronger, more bargaining power, right? And then fourth, exploring RFPs, right? See what else is out there, kind of what's working for our employees, what's not working, and then comparing the RFPs to what we already have. Obviously cost benefit coverage, those kinds of things, and seeing if it's time for a change, or just, at least having that conversation. So our idea was that this is an sort of easier one. There's some things in number 1 and 2 that we can do sort of on our own or on a lower level. Growing OEB helps, obviously, and then number 4 being our RFP, that's kind of the hammer, so that would be the big one. So that's that.
Quick questions, anybody?
All right. Cheryl's going to join. Chime in, Cheryl. Okay, so we have member education, wellness, preventative care, and equity access, and cost, and a lot of these are intertwined. We've spent a lot of time talking about modes and types of communication that we should be educating our members on. Specifically, them not seeking the information on a web page, but how can OEB push information out to them and put it in their life and on their radar versus them have to seek that. Talked about like linking dashboards on staff pages of websites of OEB information, which ties with wellness, and then you can inform people about the opportunities that are out there. What else?
So when we, member education too, I think there was a lot of discussion about language.
Yeah.
So language supported education, going out specific to your audiences. We have high numbers of Hispanic and we don't do good at translating messages that direction. With regard to wellness and preventative care, wellness is a big push that OEB has right now, which is awesome. But I think that we also discussed what comes in front of wellness. And so what are you doing to prevent so that you don't get to the point where you're spending a lot of money on getting better or illnesses or those sorts of things. And so how are you messaging out about the preventative care that's available and encouraging folks to take care of themselves? Sometimes folks have a hard time with that because it feels selfish. And so then you end up with your mental health breakdowns because now we're stressed and we're sick and we don't feel good and we're looking for a way out. Instead, what are we looking to help our people be better prepared so they're more resilient? And then I think equity and access. We talked a lot about, and we see please join in with me here, but we talked a lot about, again, the language and the equity, what's available. You brought up the online capabilities.
Yeah, so if one of our goals is to grow OEB, which it should be, we want to increase the numbers that are participating with our group, right? We have to be really effective about how we message what we have to serve and how equitable that is to everyone. It's in dual language, it's accessible for people that might not normally find it. I mean, let's face it, a cell phone is your market. That's how it works. With an app, you push it out. It's one-way communication going to them that points them to the resources they need. And school districts are using that model. That would be an effective model here, where it's like, look at all these great things we have to offer. We need to promote what we have to offer to our members and what the equity access is. And the telehealth component, we talked about that as well, and how so many school districts in the state are rural or count rural areas. The telehealth makes that an equitable practice because gas, time, and money to get to the doctor that's not in a rural setting is not equitable. And then you don't have teachers sitting in front of the kids. And so to be able to continue to use technology as a vehicle to increase our membership and make things more accessible to everyone, essentially. Did I cover it, crew? Okay.
Group 3.
So we talked about reducing barriers to entry. And this is really, it's kind of a continuation of the shift left concept where you want to make sure people are engaging with the healthcare system sooner rather than later. And the most obvious way to do that is to reduce the cost. So lower deductibles and other out-of-pocket costs. And then leveraging PEB data. We talked about questions around like why are costs so much lower for PEB members? So they have lower deductibles and their out-of-pocket costs are just generally lower. And so wondering if there are things that they're doing that we're not that we could perhaps like borrow from them to lower costs for our members. And then we talked about doing a survey or else incorporating questions in the already existing member satisfaction survey where we try to understand like a deeper understanding of member experiences relative to how much they use their insurance. So like, not just like, are you satisfied with your health insurance, but like, did you use your insurance? And then we're able to look at people who use their insurance and see if they're satisfied, both with the insurance and with the healthcare. I think like doing the blanket survey gets at a lot of people who don't have to use their insurance because they're healthy. And then also being able to stratify that by demographics and other data so that we can understand, you know, like what are our low income, what are like populations of color, what is their experience with using the OEB plans. That's cover it?
One thing, can I add one more thing on member education? If there were a platform that OEB is actively pushing out, data collection would be much easier. If someone's faced with a survey on this versus going into their email, right, they're more apt to just, oh yeah, this is how I feel about these things. And you're gonna get more instant member feedback that way. Okay, shut up.
Go ahead, Alex.
So I just wanted to talk about leveraging PEB data and some of the differences between PEB and OEB. And I think a common misperception is PEB's cheaper, but PEB is actually significantly more expensive. It all comes down to collective bargaining, and that again, that's really not something that the staff or the boards have purview over. Although, you know, your constituencies, collective bargaining, you know, I don't know. I do know that SCIU is the majority of, not the majority, but at least half of the states. Ask me how I know they really do prioritize benefits as far as their compensation. They negotiate like cost of living increases along with, you know, contributions to benefits, and they'll tell you very readily that they prioritize that over the years. That is absolutely lower than OEB. So OEB's contributions, even though we don't have that data, we just know talking to members and having family members and friends. But how those negotiations occur, again, I'm not really sure, but if you look at like an average premium comparison for an average value plan, say like a silver or gold plan, PEB versus OEB, PEB would probably be 30% more at least than OEB, but the employer is picking up the majority of that cost, and the employee has a much lower cost share than the OEB employee would have. Not in all cases, I'm sure, but on average, for sure. I mean, it's a disparity that we hear a lot, but I think it's a misperception that PEB actually has lower costs or is doing something better or different than OEB. It's all collective.
The out-of-pocket costs are lower because they are, all the PEB plans are platinum. Whereas in OEB, you've got some gold. I think one of them might be platinum. It's the Kaiser plan, but they're mostly gold and mostly silver with the gold. If you think back to the metal tiers.
But that doesn't create member affordability, because in PEB, the employee contribution is only 1% of premium. But in OEB, we have a fixed contribution amount, and so it becomes a budgeting exercise. You know, we could, if we added more benefits to OEB, reduce the deductible, or, you know, added a bunch of services to OEB, without the employer contribution cap going up, it just all shifts to additional member premium. So that's really the consideration there too, is affordability.
I just wanted to speak to how it's negotiated. So SEIU has multiple different bargaining units of all different types. They have a council where they pull different people to come together with their ideas for bargaining. And then they have a main district table that comes together and bargains directly with the state, as we were talking about a little bit in our group too. So they bargain directly with the state. If the state doesn't give them what they want, they get shut down in the city. I mean, they get what they want. They've never not got what they want.
Seems like it, yeah.
Yeah. No, I just had some meeting with them recently, and it's.
Can I just add on that real quick? Go ahead.
No, make it quick.
So, okay, I'll try to quick. So the other thing is the state can raise their own money. When we're going up against school districts, they can't raise their own money at all. And so we're under severe economic constraints where you're having to decide, am I going to get a COLA this year, or am I getting an insurance bump? Because there's no extra money. There's no way to pressure the employer to generate more funds because they're legally prevented from doing that.
I'm just having trouble like tracking all of this, and I would love the opportunity to like, if this meeting is not the right place for it, to like understand this better.
And that's my point. So
Yeah.
bringing it up here wasn't to say, to see what PEB has that we should do. It was to understand the difference in the business models, to see if there was any nuggets in there that would benefit our business model, as in the number of plans offered, as in the administration costs, as in things like that. It was not to say that PEB and OEB are competing or trying to roll that. So it was just, do they have any practices that we didn't think about? That in number of plans was one thing. Universal negotiation, that other states do. Other states don't do their health insurance through individual districts. They do it at a state level. Things like that, so that it could all be agglomerated into an understanding of what there is.
Yeah,
out
there are
there.
some differences, I mean.
So, but we're not trying to solve it here.
Oh, yeah. We can solve it right now. No, I mean, PEB is Section 125 cafeteria plan, so you have to offer the same benefits at the same price to everybody. That inherently, the Section 125 is at the district level for OEB, so that's why OEB operates more like an exchange, with a menu of options for, there's so many different variations within a school district of plan offerings, contribution shares.
And collective bargaining is done. There's 217 collective bargaining in the state for public education. There's one for state employees, right? So, but
Let's see, PEB's the employer. Yeah. Whereas OEB's not the employer. But I mean, as far as the real difference to me that stands out, maybe speak up, is PEB's a lot sicker and a lot older. It's not just that the plans are much richer, they are, but OEB's younger and a lot healthier. So that's what I mean when you compare actual plans and the cost for the premium. OEB's actually quite a bit cheaper, but it just comes down to
and it could be just a short workshop on understanding that, to understand the benefits of OEB. Right.
And I think the reason there's no like silver or gold plans offered for PEB is, why would you enroll in one of those when you have the platinum plan that you only have to pay this amount? So,
okay. The task at hand for the next 1 minute. No, just kidding. Now, let's make it like 5 minutes max. Is to take your pen. Some of these are repeated, so you only have to mark education once because education is there and education is there, right? And then we'll conglomerate or we'll amalgamate them together. Put up to 5 marks, stars, asterisks, whatever you want to do, next to the ones that you like. So hit it.
Tony's texting me and he's advocating for the RFP, so I'll go put a couple stars over there for him.
You can vote twice, right? That's legal today.
But for this group, we're asking people to vote one per item.
Yeah.
Yeah, up to 5.
Up to 5.
That's Tony.
I'm glad you guys can have a sense of humor about it. We talked as a group, we're like, should we acknowledge it, or like pretend it's not happening, or what's the best way to deal with it?
Yeah. Point about this. I still think we should do it, but I'm not sure. I gotta make sure that this is put it up.
Oh, yeah, so guys, give me a moment to slice up the union.
Thank you. Yeah, and then will you?
Yes.
Oh, yeah.
Board members, you need to
Good job recording that, girl, thanks. Oh, I'm not gonna, I don't wanna interrupt voting. Hi. Hi. Do you have to sign this? I've been talking. Emily? I left her voice last Wednesday. Still has one. Come on. I'll talk your letter. Yes. Oh, it's that far. Well, she's learning.
Like 3 years.
You can just put 5 out.
Yeah.
And we'll put stars on.
Does she know what his voices are?
Right.
Because we can know. Can't do it.
Yeah, that's what I'm saying.
Okay. Are you doing that, John, already?
I see that.
Yeah, please.
I've got one down in my trunk.
Yeah. Just make sure you can get back up. I had a hard time finding somebody to let me back up.
Oh, it's too bad I don't let you back in, huh?
Bonnie, can I bug you for your signature? Yes.
I'm not signing anything.
You're not?
Not today.
Yeah.
And you did, yeah, okay, good.
You need him to sign with.
Yes, I think.
Thank you. Is that mine? Was that mine walkable?
Oh.
Maybe.
Yeah.
All right, 1 minute. 1 minute. Okay, the polls are closed.
We have some absentee ballots.
Yeah, we got.
They got 4 days. If they're postmarked today, right, make sure they're postmarked. All right, everybody. Let's be prepared for renewal strategies.
Well, don't we want to tally up the votes, Bill?
Oh, I thought you were going to do that and present it like right before break or something, right?
Oh, yeah.
You
Sure,
got
we
it.
can do that in the background and then come back to it.
Depending on how fast you can. We'll announce it at break.
That's cool, yeah, I get it. Yeah, I think that's good. Yeah.
All right, so who is presenting renewal strategies is you, or?
I will start it off.
All right, so we're on slide something plus 2, which is 36, 38, slide 38 on the board, on the screen. All right, while the screen is getting updated, why don't we get started? Okay. Slide 36 for those in the room, right? Are we on mute?
38.
We're not on mute.
38.
No, it's open.
38.
Light screen.
No.
36 in the room, 38 on the screen. Let's, I think they're just, well, it does say we're on mute here.
Well, that's me.
That's you.
I'm on.
Okay, but that's,
But this is recorded.
oh, okay, that's on. Okay. All right.
in that case, let's just get going. So, okay.
I don't know how to text. Who's running the slides? You're running the slides, right?
Yeah, sorry, we're trying to send Dr. Laura the options.
Oh, okay.
We're trying to get this.
We'll get there.
Dr. Laura.
Go ahead. Let's get started.
Okay, so just making sure I'm oriented to what we're on.
Crafting a meaningful clinical strategy.
Okay, so 38 in our books.
Yeah, 40 there.
So as we get into sort of defining the strategy, the next section here is going to be focusing on sort of the informing aspect of this, right? So looking at the available data that we have access to, and in a way learning from the claims utilization data to infer sort of what our members or educators are seeking in terms of care, what are they needing, and then kind of extrapolating as what are some of the clinical areas that may be worth prioritizing. So that's the gist, but obviously keep in mind that at the end, you know, in the prioritization, it is about making sure it's achievable within the scope of OEB and what were our scope of influence, and that when it comes to impactfulness, also be mindful that some of these things take time, right? So they're not a one-time sort of, I'm doing air quotes for those on the phone, impactful right now, but it's a strategy over time, especially around clinical health improvement. So with that, let's kind of go through an example of what we've done in a previous iteration. Next slide. The clinical strategy process is sort of the select, assess, and act kind of framework. And in this example, you know, one that's top of mind is the cardiometabolic condition or disorder. Just to reorient everybody, cardiometabolic is this sort of clustering of health conditions that are so interrelated, meaning if you have one, it can develop into the other if we don't sort of optimize it. And it all centers around cardiometabolic or glucose metabolism at the heart of it. So they do include type 2 diabetes, which is one that's later on we'll dive into in terms of how prevalent it is in the population, who's getting care for that and things like that. But it also includes other cardiac conditions like high cholesterol or hyperlipidemia, high blood pressure, and it includes overweight and obesity. So these things kind of go together, and each of those are sort of medical labeled, but at the heart it is about glucose dysregulation. So when there's that condition, it's leading to these onset of illnesses and diseases that we're treating. So that's why we're talking about this holistically, because it's hard to just say we're kind of focused on one. So I'm going to use cardiometabolic conditions as a wrap. So when we had that, we looked at the data, 2022 to 23 and 23 to 24. We were seeing an increasing diagnosis rate of all those conditions that I described, and the prevalence was increasing, not just for OAP, but also nationally. So, you know, this is one of those scenarios where it's not just something that we can isolate and address through OAP uniquely, because there's other factors. Obviously, there's a genetic component to it, but there's environment, there's social determinants of health, community, food, industry. All those things are playing a role. So when we came down to assessing, again, it was about what can we do through OAP's scope of influence to support our members and our educators for those that are seeking to improve or address their cardiometabolic conditions. So at that time, we assessed what was in place from a point solutions, looked at the utilization that was underway, and then identified gaps. So, you know, part of the outcome of last year was to sort of reconfigure the point solution landscape and sort of make it a little bit more robust, but also start to address some of the gaps that we were seeing of individuals that may not be aligning to those partners that were available. So that's where we added things like Mighty, expanded Verta, etc. So those are the assessments that we made, and then the acting on that was submitting that to you know, whether to support to move forward or not. And that was gone through a vote, and our plan design this year was reflective of that. So Moda added Virta as a type 2 diabetes, a reversal option mostly centered around dietary management. And around diabetes management, Kaiser reduced the maximum monthly copay for insulin as an option, and so on. One thing that we did discuss, just for completeness, obviously the GLP-1 medication is a type of medication that addresses the glucose dysregulation. So it is used for type 2 diabetes treatment, but it also, as we all know, has impact and can improve those individuals with obesity, which is also a related risk factor. Again, the goal is not just to reduce the weight, but it's underlying that cardiometabolic glucose dysregulation that leads to those conditions. That did not pass, so that is sort of in the wings currently. But that was just for the treatment of obesity. Obviously, GLP is available and is covered for type 2 diabetes.
Can I ask a question?
Yes.
Have the new drugs been on the market long enough? Like I know in other countries, you can get a prescription for a GLP-1 for obesity alone without the other conditions. Like, is there data yet that we know if it does prevent the other sort of factors from developing?
So this is evolving science, so fair point. And it's one of those things that we have initial clinical understanding that it can improve dramatically as reflected in obesity, but it improves the glucose dysregulation underneath. That can reduce the onset of type 2 diabetes, that can reduce the onset of cardiovascular disease. But that requires maintaining that improvement of your glucose dysregulation. So these are the options. Either you stay on the medication if that's the only thing that changed, because that's the intervention that was introduced. Or you combine that with intensive lifestyle intervention, so it's sort of leveraging both options and you try to maximize it. And this is where we still have room to learn, meaning some people you can come off the medication because some of your lifestyle changes or your choices and things like that have improved, that it can sort of start to sustain. It's not going to be for everybody, but those are some things we only learn through time of use.
For our purposes, I just wonder if opening up access would, in the long run, save money for our members by reducing the folks who will otherwise go on to develop diabetes or the other conditions related.
So long-term studies have shown that there is a potential cost benefit, but it's not in the first year that a person is on it. It is over time. And so this is where it gets hard as a group that is thinking about GLP-1. So I've had these conversations with other groups. And here's the two extremes, right? So potentially, if you're a retailer and you have high turnover, like every year, the employees don't stay longer than a year, and they're generally younger, covering that financially, there's no cost benefit, because the 1 year, you're just starting to reduce improve the glucose dysregulation, reduce that weight a bit, but then they moved on, right? So that's one extreme. On another extreme, a high tenure, the age distribution that happens to be the group that the prevalence of obesity leads to type 2 diabetes, that's where it happens, tends to be in your 40s. So groups with a high prevalence of 40 or higher and long tenure, and yes, they will eventually impact the plan, but they need to be at least 5 to 7 years is the current sort of economics studies. So that's a trade-off. And you need enough people that stay on it. Then you get into things like waste. So some people come on off of it and on it. So you get the yo-yo phenomenon. So at $1,000, that's significantly impactful, right? If it was a generic medication and we weren't adherent, that's the terminology that we use for taking the medication as prescribed. It kind of bleeds out, but at $1,000, you end up wasting it because you took it 1 month and you went off of it for 3.
I think just another data point to add, and I know the population is different, but Medicare, has been looking at, there's been a lot of, initiatives at the federal level to try to see how could weight loss coverage be added to Medicare. And the CBO, the Congressional Budget Office, released their their estimates just in the last few weeks. And what they estimated is that for each person using a GLP-1, the cost would be about $5,600 a year, going down to closer to $4,000 by 2034 because of generics and price pressure. But the average offsetting savings would be $50 in 2026, because again, it takes a long time to generate savings, going up to $650 per year in 2034. So they're recognizing some savings, but there's not enough data yet for there to be enough savings to offset the
For
high cost of
65
the
and over
drugs.
though, because they're
They're
65 and
and
over.
up.
They're,
right.
Like, it would be interesting to see.
Right.
If you started at 40 instead.
Right, yeah, and we don't have the data for that yet, but I thought it was an interesting, it was the first time I had seen that kind of long-term calculation done.
Okay,
Yeah,
along
wait,
question. Yes.
So we discussed this last year, and I think some previous board member asked, there's a lot of research that's happening when it comes to this sort of drug, in the field. Since then, have we had more drugs or different pharmaceutical companies or different vendors that are providing this type of drug that are more cost effective that we have to explore, or provide the same level of data points that speaking of that we can maybe potentially look and save more money? Or
So far, there's only Novo Nordisk and Lilly, so Wegovy and Zepbound remain the only products there that are available. There's also Saxenda, which has been on the market close to 10 years now, but it's a daily injection. It doesn't get used as much. It doesn't seem as effective, but we haven't seen more entrants yet. We're expecting more, probably in 2026, some additional products.
Aren't there compound formulas?
There are compounded pharmacies, and that is kind of a complicated topic. Bill and I were talking about that. But yeah, there's compounding pharmacies, and currently compounding pharmacies are technically allowed to make kind of versions of FDA approved products as long as those FDA products are on the shortage list. And now the FDA has recently announced that Zepbound is not in shortage anymore. They were promptly sued by these compounding pharmacies. We'll see where that lands. The difficulty is a lot of the compounding pharmacies are operating in a regulatory gray area. It's because they're compounding something either that's a mimic of an FDA approved product and you get into patent challenges there, or they're compounding it with other ingredients, like the different salt versions, and that's not technically legal either. The FDA sent out cease and desist letters to some of these pharmacies. But the fact remains, they're out there, they're everywhere. They're advertising online on every social media for, $200 a month rather than $1,200, $1,400 a month. But you're not getting the same level of oversight. There's it's challenging, And whether or not they'll be able to continue to compound depends on what happens both with the shortage list and then also whether or not the FDA is going to start enforcing.
Mm-hmm. And then like you, I would be curious to see even maybe a younger demographic, because there's some interesting information out there that like GLP-1s are a helpful or effective treatment for PCOS, right, which causes fertility issues. And fertility treatments are really expensive. You're not going to see that in the 65 plus demographic, right? But you will see that in 20, 30, 40s, right? So I think like with